All right, team. Welcome back.
Hey.
So how was everyone's week?
All right.
It's so awesome.
Been hard.
All right, we
Let's
can
get
start
to it.
reading mini illness scripts.
Should we just like very briefly kind of just like read through the problems list for the
Yes,
first
go again.
patient?
Yeah, yeah.
Or
That's a
else
good
I
idea. Yes,
just
go.
don't remember.
Yeah. Why don't
Okay.
you do it? Yeah, it's a good
I'm
idea.
just gonna read through the problems list. So it's homeless delusions, progressive falling and exhaustion for 6 months, tongue pain, electric tingling sensation down her back, in both legs. She's on metformin and omeprazole. Traveled very far to see Elvis. Blood pressure 150 over 90, BMI 29, absent, Achilles, reflux, loss of vibration on toes and ankles, positive around birds, another fall, inconsistent thinking and delusions, can't recall objects after 5 minutes, and can't subtract or repeat phrases, low MoCA, Montreal cognitive, whatever, disorganized thought processes, negative drugs, strained confabulations, hypersegmented neutrophils, macrocytic anemia, pancytopenia, elevated prolactin, elevated lactate dehydrogenase, elevated creatine kinase. Okay, so now our diagnoses. You had the first one?
I think I had the first one, right?
Trying to find the list.
You have vitamin B12. Okay, so I'll start with vitamin B12 deficiency. Okay, so vitamin B12 deficiency just happens when your body isn't getting enough vitamin B12 because it's something that you need to get from the food that you eat, and it's important because it helps your body make DNA. So like it's like very problematic if you have B12 deficiency because it makes DNA. Okay, and then possible causes are like diet. So if you don't eat foods that naturally have vitamin B12, another common cause is gastritis, and there's also pernicious anemia, which is like autoimmune destruction of parietal cells. And the parietal cells in your stomach produce HCl and intrinsic factor, and then the intrinsic factor is necessary for B12 absorption. So that's another common cause, especially in older people. And then less other common causes are if you have surgery to remove like the terminal ileum, because that's where it gets absorbed, alcohol use disorder, surgery, or like transcobalamin deficiency, which is what transports it around the body. Yeah. And then for core concepts, I put like flow gradient, blood flow, immunodeficiency. So like common symptoms are feeling tired or weak, weight loss, experiencing nausea, vomiting, or diarrhea. And neurological symptoms like numbness or tingling in the hands and the feet, and then having like a hard time remembering things, or like getting confused really easily, and difficult time walking and speaking. And some signs are they have some vision problems, and then diagnostic test is just CBC and then vitamin B12 blood level to see how much is in the body. If it's less than 150 milliliters, then that's indicative of the condition. And then the treatment is just cyanocobalamin, which is just man-made form of vitamin B12, and you just give injections.
Okay, I think I have the next one. So, Wernicke-Korsakoff syndrome. So this one is caused by a deficiency of vitamin B1 thiamine, and it classically presents with ophthalmoplegia, ataxia, and altered mental status. So it's caused by a thiamine deficiency, which can be secondary to a few things. So chronic alcohol abuse, which impairs the absorption of thiamine, starvation, strict diets, like malnutrition in general. If you're not getting that nutrient in your diet, terminal cancer, bowel obstruction, IBD, bariatric surgery. So if your gut's not working, you can't absorb it either. And then this underlying thiamine deficiency can be exacerbated by glucose loading, so it'll come out in patients when they get into the hospital, and if they're given IV glucose alone without thiamine, if they have the deficiency, then it can become more apparent and they can have symptoms. So the pathophysiology, thiamine is a cofactor for enzymes involved in several biochemical pathways, including bridges between glycolysis and the citric acid cycle. So deficiency results in metabolic imbalances, which can lead to neuronal cell death. The syndrome is characterized by brain atrophy, with the mammillary bodies being most prominently involved. There may also be damage to the dorsal medial thalamus, periaqueductal gray, the walls of the third ventricle, the tectal plate, and the cortex. Damage to diencephalic structures is responsible for memory loss. Damage to the abducens nuclei and eye movement centers in the midbrains and pons impair eye movements. And damage to the superior vermis causes ataxia. Core concepts, I put word metabolism and cell death. So you can have, for symptoms, ocular would be diplopia, strabismus, painless vision loss, and nystagmus. Gait abnormalities are like wide steps, short steps, need assistance to stand or ambulate, and you can have altered mental status. And then as the disorder progresses into the Korsakoff syndrome, patients can develop hallucinations and confabulations. And then signs are erythrocyte transcutaneous activity, lactate, and then for MRI you can look for the hyperintense signaling in the affected areas, including the mammillary bodies. And that's it.
Who did pernicious anemia?
Did Mary have that one?
Mary isn't here, so we'll skip
Well, I mentioned pernicious anemia
Okay.
and what it was, I guess. Yeah. Okay, who did diabetic peripheral neuropathy?
I did diabetic peripheral neuropathy. Yeah. So, wait, hold on. Okay. So diabetic peripheral neuropathy is a complication of diabetes mellitus. So you get nerve damage from increased glycosylation products, and the common causes are obviously diabetes and hyperglycemia from diabetes. Advanced age also causes diabetes. And the duration, if you have increased duration, it also increases the risk of peripheral neuropathy and various cardiovascular risk factors, autoimmune factors, genetic predisposition, and of course lifestyle factors. So the pathophysiology or etiology is kind of complex, but the main thing is you get increased oxidative stress, metabolic changes, and microvascular changes from the increased glycosylation products everywhere in the body. And basically all these glycosylation products cause chronic inflammation and demyelinate the nerve and cause nerve damage. And the common symptoms are numbness and tingling, burning, shooting pain, loss of sensation, muscle weakness, loss of coordination, and foot problems. And clinical presentations include that you start asymptomatically and then worsen gradually, and symptoms may vary from person to person. And for mechanistic core concepts, I put chronic inflammation, glucose homeostasis, and flow gradient, because if you have an increased level of glycosylation products everywhere in the body, it obviously messes with the transport of stuff. And associated tests include clinical assessment, neurological examination, nerve conduction studies, which measures nerve function, electromyography, which evaluates muscle activity, and skin biopsy and blood tests. Treatment include obviously treating the underlying problem, glycemic control, pain management, physical therapy, foot care, lifestyle modifications, and symptom management.
Okay, great. Thank you. I think I did the last one. Okay. So I did Alzheimer's. So Alzheimer's is a progressive and irreversible degenerative neurological disorder that affects cognitive functions, specifically memory and thinking skills. So it's the most common cause of a decline in cognitive ability accounts for 2/3 of cases of dementia in people 65 and older. There's a genetic role, and other risk factors include traumatic head injury, depression, cardiovascular and cerebrovascular disease, high parental age, smoking, and then higher education, use of estrogen by women, and like reading and playing music and healthy diet and exercise decreases risk. For pathophysiology, it's characterized by accumulation of abnormal neuritic plaques and neurofibrillary tangles. So amyloid precursor protein is normally cleaved by alpha or beta secretase to form like fragments that aren't toxic, but if it's cleaved by beta and then gamma secretase, then it forms the beta amyloid 42 that is toxic, and the beta amyloid favors the formation of the fibrillary amyloid protein. And then for core concepts, mechanistic core concepts, there's genetic factors influencing development, waste and toxin disposal, and cognitive function. For symptoms, it's memory loss, poor judgment, losing track of dates and current location, taking a long time to complete normal daily tasks, repeating questions, and forgetting recently learned information, mood and personality changes, getting lost, so things like that. Signs, the physical exam is normal except for anosmia. Brain CT can show atrophy and widened third ventricle. CSF analysis can show low beta amyloid and elevated tau. And then EEG shows generalized slowing with no focal features. For diagnosis, there's not a definitive diagnostic test, but you do a neuro exam and blood work to rule out any other causes, and then a mental status exam, and the brain imaging and CSF. And there's no cure, only symptomatic treatment. The two drugs that are approved are cholinesterase inhibitors and NMDA antagonists. So, what do we think it is?
How old is she?
B12 deficiency.
I still think it's B12 deficient.
Her blood smear is like there's deficiency there.
Guys, I'm forced to pass this out.
Oh,
That's good.
It's a welcome thing. There's a QR code. You guys could win a reward. Sorry.
Thank you.
Okay.
Thank you.
Because of like the
Hypersegmented neutrophils. Yeah, yeah.
That's pretty indicative.
Pretty, it's pretty specific
of
finding.
pernicious and B12 deficiency.
Yeah.
I mean, she could have both though. Like,
Yeah.
Like
She
if
could
she's
have
deficient
both.
in one nutrient, like I'm guessing that she doesn't have a super high quality diet. Like
Yeah, that's what I was
she's not going to be eating a lot of fruits and vegetables, or I mean, I guess you get B12 from animal products, but
So much water.
I'm just thinking if you have one, you're likely to have.
So like both, like B1 and or B12 and B.
Because did the B12 deficiency cause like neurologic symptoms? Because at least with
Did you say confusion?
B12
yeah,
causes yeah, confusion too.
okay. Because the B1 could be
Yeah, it can cause.
So couldn't it be that? Oh, okay.
I mean,
Could be
in
that,
theory-
but I think she would probably have more like GI symptoms though
Yeah.
too. I don't think she has any.
it's unlikely that she only has B12.
Yeah, especially
she's
with
gotta
the like
have, like,
confabulation.
multiple-
That it seems like she has.
Yeah, maybe she has something else.
That could explain some of, like, I don't know if that explains delusions, but like definitely giving like weird answers. And like if she's
Yeah.
falling, that could be from the gait instability.
Yeah,
Yeah.
they would think it could be both B12 and
like a
then
vitamin
Wernicke
deficiency.
corpuscle.
Combined vitamin deficiency.
Yeah,
I mean that doesn't sound unreasonable.
Wait, so
And she
so
could
you have
probably
any
have
problems
diabetic
with stomach
neuropathy on top of it.
You're
Like
actually
that's
taking,
not
like,
impossible.
Yeah.
Omeprazole.
omeprazole.
So
Omeprazole.
It's like,
combined
'cause
dietary.
like we know that she has
Yeah,
like
gastritis.
we know she has
Yeah, like,
diabetes.
What is
Part
that?
of
So,
Yeah.
and if she's not, if she's homeless, chances are she's not taking her medications as regularly as she should be. So,
Your
like,
call.
is it bad if we just say all of the like, put
Also
those three?
diabetic neuropathy.
Well, both vitamin deficiencies plus diabetic neuropathy. Like, is that, or at least list those as the top three?
Yeah,
'Cause
those are for
they
sure
could
the
definitely
top.
all co-occur. Like,
Those are
there's
the
no
top
reason that they
three.
couldn't.
Yeah.
Sounds good.
We have to put whether we think Wernicke-Korsakoff is still possible or unlikely. So still possible.
Possible.
Yeah.
And then we need to explain why we
The
took out,
diabetic neuropathy is still possible.
well, Alzheimer's. So we
Oh, she doesn't use that.
so we didn't include Alzheimer's.
How
We
old is
have,
she?
So I guess
I don't
that
Did we figure that out?
Let me look at this.
this is for
This is cool.
we are PIQing.
Oh, really?
Yes.
Oh,
It's
icky.
going.
She's 50.
We're also
No, we love PIQ. We love it.
favorite part of the week.
She's 50. So we can write that down.
Yeah, it's it's less likely.
Wait, guys. Also, like,
Oh, that she has
anemia.
Yeah.
Yeah, probably.
Yeah.
Like, look at her CBC.
Yeah.
Yeah, that's
Low
from the B1
hemoglobin.
deficiency.
Yeah.
But could it also be from just anemia?
That could cause the B12.
Yeah.
But like either way, you have the B12 deficiency.
Yeah.
So
Yeah, B12 is pretty like.
But, like, to have them as two
confirmed.
different
It was
diagnoses
the
is not like
I think so. Like
pretty related.
I don't think there's a long list of things
Yeah.
that cause that. So, well, if we have to
Let's do
list
that.
3 diagnoses, then we can just list those 3.
Yeah.
Because so the patient is 50.
It's like folate
And then it doesn't
and
explain that.
about like a lot of symptoms overlap
The
anyway.
blood.
Also, the
Yeah.
creatine
And this
kinase.
condition doesn't
Oh,
explain.
folic acid or vitamin
Like her
B12.
anemia, right? Her macrocytic anemia.
The lactate dehydrogenase is high.
What?
What?
It's okay. I'm just looking at the lab values.
Oh,
Let's just say B12 only.
That's not what we're saying.
Is there anything that goes against diabetic neuropathy?
I mean, confusion. Like,
Oh yeah,
it's
that's
not
like the
entirely
mental
against
one.
it. Oh,
I mean, that's just something
blood
else to
smear?
explain.
yeah.
But I mean, she
Oh,
could also
Because
have
we'd
it.
definitely be listing that as something that just like explains a couple symptoms.
Like, it doesn't explain everything.
yeah.
She could have it.
I don't know. Are they looking for like one condition that umbrellas everything, or are they going for like recognition that a lot of patients have comorbidities? Like you're rarely going to see a patient that's like, I just have the one, or at least like of her age and situation where it's like, I only have one problem and everything else is fine.
I think they want the one problem that, like,
That gets most of it.
Yeah.
Yeah. I mean, that makes sense.
but obviously there's like comorbidities, so. And, like, she's also diabetic, right?
Yeah.
I don't think you just take metformin for fun.
Yeah, no.
But she probably has like all of it. Like all the things that we like.
Right.
Like
Anything else?
What
we
are
need to-
Wait, so evidence that goes against B12.
Yeah, is there evidence that goes against it? I don't think so. Let me look at
The
the
one thing I'd say
Let me look at the
against, like,
problems list.
yeah, against the Wernicke-Korsakoff is that I think what she's saying is going beyond just confabulation. Like she's saying things that normal people would not just come up with to like try to fill in gaps in their memory. Those are like a disconnect from reality, which seems to verge on schizophrenia, which we didn't look up.
I mean, I don't really know what the elevated prolactin has to do with B12 deficiency. Or,
Yeah, I was
right? Yeah. Why is prolactin elevated? It's elevated when there's not a lot of dopamine, right?
Yeah.
Oh yeah.
Prolactin.
Dopamine is
Elevated.
But don't you have too much dopamine in schizophrenia? Wait,
Yeah, it doesn't really, because usually that's like a side effect of like
that's the
taking
antipsychotic
medication.
medications.
Yeah. So
Yeah,
it's
white
kind of
blood
like
sugar
why.
levels go up.
That
Yeah.
shouldn't be a symptom of.
Yeah, I don't know.
What
It's
about
here.
the electrical tingling
mean-
sensation? In the back of her head,
I guess
the both legs.
the
Ridiculous. What was that even?
I guess not specifically in the hypothalamus, but like there's degeneration in a lot of like related areas and
Probably from her diabetes.
thiamine deficiency.
That makes sense.
So
Yeah.
Oh, I mean B12.
maybe it could be
yeah.
affected.
Wait, what did you say?
Oh, like there's degeneration of brain areas like kind of in the neighborhood of the hypothalamus and thiamine deficiency, so maybe that could affect the prolactin.
That makes
I'm not
sense.
saying like that's a great
Yeah.
reason, but it,
Have prolactinoma.
So we're suspecting
Why not? She could also-
Wernicke's aphasia also as well, right? So if she's like alcoholic, or if she uses alcohol,
I don't
it
know if she
also-
does.
I don't think she does.
she denies it, though, right?
I mean,
Like
Why do-
all of
why
She has
do
a
we have
negative
that?
drug screen.
I don't know if that
I mean, I guess
alcohol is
if alcohol
So it is true that she
drives
doesn't.
it.
Okay.
like everything else is negative.
So then why do we have a Wernicke's at second?
But look,
Well,
if
you
she's
can have.
homeless
You don't
and
have to be
something
an
right now have
alcoholic
like
to
a
have
nutrition.
Well, like,
Yeah.
talking about thiamine deficiency.
Yeah,
thiamine
thiamine
deficiency.
deficiency. Yeah.
So it kind of seems like
Because that one is
general,
the
she's like malnutrition.
like fruits and vegetables, which
Yeah, that could
you're
be
not
right.
likely to eat very many of.
Okay, wait. So you add it. One. Plus 1 over 6 plus 1 over 6 that equals 6
So it seems like if you roll a dice 6 times, there's not a guarantee that you're going to get you have to do the upgrade to a 5, 6. It is the probability
Alright, guys.
Should we go to the
Now it's
manage?
12:33.
Should we go to the management?
5 over 6.
Yeah.
Okay, so
Management. Imaging. We already got CT. Well, I don't need any more.
cyanocobalamin.
Procedures.
Right, but you have to see back. Or that's
How do you treat it in last lifestyle medicine, Jess?
Diet.
Diet.
Hey, what about the Schilling's test?
I don't know.
Remember that one?
You got it.
Remember?
Yeah.
Yeah, that's for immune hemolytic anemia, isn't it?
No.
What is
Oh, no, yeah,
HSS?
think of another
System
test.
science?
Yeah.
Sorry, not Schilling's test. Thinking of. I don't know, the B12 deficiency test.
so you find if you roll do 5 over 6 to the 6, you're fighting the probability that it will never be.
Specialist, consultants,
You're saying that none of this, yeah, that's the probability that none of it will be a 6. So then you subtract that.
and endocrinologist. Consult.
Go 5 or 6. And then that's the probability that you're going to get no 6s.
Basic medicine. Review.
I don't know about procedures.
Cohort studies on
Procedure would you do?
IV B12 administration. I don't even know if that's a thing.
B12 injection is a thing.
Yeah, that's one of
Yeah,
the things
you-
that you do for alcoholic, right? With B1.
Yeah, I
for-
think so.
Gotta give them glucose too.
Say it. You should write it down.
Alright, looks pretty good. Okay, wait, sorry. Make decisions based on evidence-based research.
I haven't listened. I'm just watching Dara get lost 5 seconds in.
Alright, guys, so we reached a consensus here.
Yeah.
So, yep.
I think we
I
did.
think it's B12 deficiency.
Okay.
Organ key course.
And we're an diabetic
I think it's
neuropathy.
3 of them.
Yeah.
Alright, should we move on to the
Yes.
B?
We're moving on to case
Alright
10.
guys, 1236.
Okay, who wants to read the problems list? I'll read it. Okay. So,
Sorry, I was scrolling.
we have homeless, altered, LOC. What is LOC? Oh, level of consciousness. Suspected seizures, anti-epileptic drugs administered, temperature of 100, pulse of 100, shortness of breath with intermittent cough, decreased breath sounds in the left posterior lung fields, 1.5 centimeter right submandibular soft lymph node, 2 centimeter right axillary soft lymph node, left upper 1/4 anonymous hemianopsia, poor dentition, multiple insect bites on the lower extremities, findings consistent with head lice, right temporal brain lesion excision showing extensive necrosis, high nuclear to cytoplasm ratio, and fine nuclear chromatin in the brain lesion. Positive for chromogranin A, synaptophysin, CD56. PET scan shows increased flu deoxyglucose uptake in the right axillary node, high mitotic rate, Ki67 rate of 25%, increased respiratory rate, cough is becoming more pronounced, and denser hilum on the left lung than the right lung. Okay, so
Alright, let's go to mini illness scripts, I guess.
Yeah. So,
So-
small cell carcinoma. Is that
Yeah, I can show you. Illness script.
So you know his blood level.
Okay, so small cell carcinoma is a lung with brain metastasis. So what is it? Small cell lung carcinoma is defined by light microscopy as a tumor with cells of a small size, round diffuse form shaped scant cytoplasm, finely granular nuclear chromatin, absent or inconspicuous nucleoli. They originate from epithelial cells and up to 90% express thyroid transcription factor 1. Cytokeratin can be used to distinguish small cell lung carcinoma from lymphoma and other neuroendocrine tumors. The median survival is 2 to 4 months without treatment. Risk factors strongly are associated with smoking, has a higher prevalence in males and Caucasians. The pathophysiology, there's various pathways that are disrupted that have to do with normal DNA repair mechanisms. Common mutations include loss of RB1 tumor suppressor genes and TP53 mutations, which decrease pro-apoptotic activity of cancer cells. Almost all of these tumors have deletion in the section of the short arm with protein 3, having to do with tumor suppressor gene FHIT. So someone that has small cell lung carcinoma, they might have coughing, wheezing, hemoptysis. If it's metastasized to the brain, they may have neurological problems, recurrent hurricane, fatigue, anorexia, headaches, blurry vision, nausea. You want to order some laboratory tests to see exactly what's going on. You'll want to check for paraneoplastic syndromes, since those are really common. Well, at least small cell lung carcinoma is the most common associated cancer with paraneoplastic syndrome.
Yep.
Yeah.
So things like electrolytes, blood count, calcium, phosphatase, alanine aminotransferase, aspartate, bilirubin, creatinine. The most common paraneoplastic syndromes associated with small cell lung carcinoma would be syndrome of inappropriate ADH, ectopic Cushing syndrome, and Lambert-Eaton myasthenic syndrome. Associated diagnostic tests. Want to get plain film radiography, radiography, and contrast enhanced computed tomography of the chest and upper abdomen, and then you want to get a brain MRI and PET CT. For treatment, if it's in the limited stage, you can do a lobectomy with mediastinal sampling or dissection if the cancer is T1, 2, and 0 positive, and if they're a surgical candidate. If you're not a surgical candidate, you want to do stereotactic ablative body therapy. If it's in the extensive stage, then you'll want to start systemic chemotherapy.
Like at Better Buzz, I wanted this lavender latte.
Whether I think it's likely or not, I guess none of the biomarkers in the case match the biomarkers I just listed, so I don't think it's very likely.
Wait, it doesn't match?
I didn't think so.
Oh, really?
I thought it was-
Oh, I thought you said it did.
I thought
Wait, synaptoplasm.
Wait, it's not chromogranin A and synaptic vision? It's on that?
Oh, I didn't see it specifically listed.
Oh, really?
I thought it was neuroendocrine.
Or like
Neuroendocrine, right?
Yeah. I thought
Neuroendocrine
I thought
markers.
neuroendocrine.
Oh, what's our second one?
Well, the second one was just a random brain cancer, so I picked one. But I'm starting to look, and like the markers also don't match.
No,
Anyways,
it's fine.
so mine was glioblastoma multiforme, and it's an aggressive tumor that arises from glial cells in your brain. Etiology causes risk factors. There's not a lot. It's pretty much just sporadic. I mean, there's not a lot of evidence even about like lifestyle factors that can contribute to it. So it's kind of just like, oh yeah, you're really unlucky to get it. Underlying pathophys, I mean, similar to most cancers, a lot of mutations that lead to, you know, rapidly proliferating cells. In this case, it would be the glial cells. And it's called multiform because there's a whole bunch of different mutations. Anyways, core concepts, I just said cancer. It's cancer. Affects your cognitive function, obviously affects the brain, and I'm sure it's very painful. Clinical presentation, signs and symptoms include headaches being the most common, seizures, neurological deficits, increased intracranial pressure, and symptoms like nausea, vomiting, blurry vision, and altered mental status. Diagnostic tests such as brain MRI, head CT, and of course get a biopsy if you can. Associated treatments, surgery if you can remove it, radiation, and chemo. Likelihood of it being correct, I'd say somewhat likely, maybe.
Does it metastasize to the lung?
Well, probably.
I think some of them are more likely to metastasize to the lung. I forgot which ones.
Probably not this.
Okay, interlude, addendum. I think it's very likely. It's just the two NIH resources I was looking at first didn't have CD56 listed anywhere in them. Like I didn't search. I was like, oh well, okay, that's weird with CD56, and then I like Googled it now, and now this other NIH one is saying small cell lung carcinoma. So thanks a lot, but I don't know.
Well, I just
So you
found
think
an
it's-
article that says that adenocarcinoma and squamous cell carcinoma express all three of those markers that were listed. Like not a high percentage of them, but so it's 18% of adenocarcinomas and 50% of squamous cell carcinomas were positive for either synaptic vision, chromogranin, and CD56 or combination. So
something
So if
metastasized
we're
in a
looking
lot of different
for
places.
a lung cancer, it looks like it might be those two. But
Hmm.
I don't
more
know if they
likely-
considered small cell.
Yeah,
so.
because I'm seeing small cell carcinoma, and it was
No, actually. I think it's nice.
I haven't read it. I
Specifically
just pulled it up.
I think it's more likely that it started in the lungs and then metastasized to the brain. That's probably more likely. 'Cause I'm pretty sure like before like it metastasizing from the brain, you probably like got.
Yeah.
Yeah.
I need to up my movement skills. So embarrassing.
I'm seeing that it says CD56 is found in
Yeah.
small cell carcinoma. Small cell carcinoma.
Okay. That's.
I'll put this down.
Hey, that.
I put it down on, yeah.
Okay, did you already?
Oh, it frequently goes to the brain as well. That looks like a better diagnosis than glioblastoma.
I think we can keep that as a top.
Yeah.
It's like if the tumor markers fit, it's a good nod in its favor.
Okay, hooded metastatic paraganglioma.
Mary Marcinia.
Oh boy.
Okay, well,
Alright, we'll skip that. Okay. Rest in peace. Okay.
Prayers.
Hopefully it's not that.
Prayers.
Okay, I did carcinoid tumor. So carcinoid tumor is type of slow growing cancer that starts in the neuroendocrine cells, which are found throughout your body and help your body produce hormones. So like it's usually people having certain medical conditions that are more likely to develop it. And some of those conditions are like tuberous sclerosis, von Hippel-Lindau, neurofibromatosis type 1, multiple endocrine neoplasia type 1, atrophic gastritis, and familial small bowel and neuroendocrine tumor. And it says that researchers don't really know what triggers the cell growth that causes carcinoid tumor, but it's associated with a lot of inherited syndromes, as I mentioned before, and also MEN1 and MEN2. Yeah, and but they're most commonly found in the intestine or the lung, and then where like the neuroendocrine cells release serotonin, and then serotonin reaches the systemic circulation, and then that's what causes a lot of the classic symptoms like episodic flushing, diarrhea, wheezing, right-sided valvular disease, and niacin deficiency. And then for core concepts, I just put cancer may be sporadic or genetic, DNA replication, telomeres. So the symptoms are like flushing, your skin can become like red and hot, nausea, vomiting, wheezing, and the signs are like abdominal pain, anemia, diarrhea, fatigue, low blood pressure, and weight loss. And then the tests you could do like an endoscopy because it's usually in the GI tract, or some biochemical tests. And then treatment could be like a octreotide, a somatostatin analog, or surgery.
Do you think it's that?
I don't think so.
Nah, probably
Did you say it's slow growing? This one's fast growing.
This one is carcinoid is
that's
slow
slow
growing.
growing.
Yeah, this is
No, this
fast,
happens
right?
fast.
Yeah, so I would not probably include that in the top 3, but
Maybe number 3. We'll see.
we'll look at the other one. Hooded disseminated.
I don't think that's going to explain the tumor. So, miliary tuberculosis is lymphohematogenous dissemination of Mycobacterium tuberculosis. So it can go kind of anywhere. Characterized by tiny tubercles that resemble a millet seed. So it accounts for about 2% of TB cases and about 20% of extrapulmonary TB cases. So this doesn't even account for tuberculosis. Like all of the tuberculosis outside of the lungs, this is just a subset of that. And so risk factors are if you're immunocompromised, and then malnutrition, smoking, diabetes mellitus, post-surgery, chronic kidney disease, underlying malignancy. So just kind of all the things that put you at risk for stuff in general. So it can develop either during primary infection or reactivation of M. tuberculosis. and then it embolizes to the vascular beds of various organs. So neurological involvement is characterized by a headache secondary to tubercular meningitis. It may or may not involve tubercle formation and motor and sensory impairment. Skin, musculoskeletal, and abdominal involvement can also occur. Clinically significant involvement of the heart or kidneys is rare. And for mechanistic core concepts, I have infectious diseases, 3D relationships, and flow gradients. And symptoms of the classic acute miliary TB, which is going to be in people about age 40 and younger, are symptoms according to the involved organ. And then some just more general ones of fever, night sweats, dry cough, sometimes with hemoptysis, and shortness of breath. And then cryptic miliary TB, and that's if you're over 60, would be weight loss, general debility, and no fever. And then signs on either chest x-ray or high resolution CT, you get diffuse miliary infiltrate, so it's like little millet seeds. And then histopathological evidence of miliary tubercles, and then elevated acute phase reactants.
Cool. So for our top three, right now we have small cells number 1. Glioblastoma number 2. Carcinoid for number 3.
Yeah.
Okay, sounds good.
Sounds good, guys.
And then why are we eliminating disseminated miliary?
Could you just write something for why?
Yeah.
Probably is
It wouldn't explain the massive brain lesion.
Yeah, I wouldn't, yeah. Okay. We need another foreground question.
So wait, do we not have to do the thing?
Oh, I guess we don't have to do the
The
one we
Renee?
just did.
Yeah.
Yeah.
Oh,
I don't see it here.
It's not in there.
All right.
awesome.
Then we're
So-
good to go.
Good to go.
We're done?
I think we're
mean,
done,
I think
right?
so. So we figured out diagnoses.
We don't need one more foreground.
Well,
Did
let's
we
do one
do
more foreground.
problem
So like,
representation?
do like.
I'll do it since I was.
Okay.
Oh, what about the
Wait.
team leaders? Wait, who was this? Josh, was it you?
No, I think it was Jess.
think
this
it was-
time.
Oh, yeah.
Oh, you and who? Yeah, fill that out. So
Just did
Oh.
excellent.
Wait, what am I supposed to do?
wait, co-captains?
I mean, we do need to leave in a few minutes, so that
Yeah,
could probably.
I'll do that. I'll just fill
We can
this
do that
out.
later.
Right.
So who is going to submit this?
Who's the
I was a scribe, so I
Okay.
can submit it.
You can
Okay.
submit it. Okay.
Once.
I'll submit the video.
okay, I'll fill out this thing later and then you can I'll let you know once I fill it out.
All right.
All right.
All right.
Bye-bye.
Bye.